Good morning. Just a quick post. We ran our workshop on the weekend, and the collaboration's already starting to work. Great to hear feedback from everyone. It's been overwhelmingly positive. And yesterday I received a few emails and some clinical emails. So I thought we'd just work through these two cases that have been forwarded on to me, and just to highlight that that's exactly what the college is all about. It's about collaborating. We're all striving towards getting better outcomes and using our overall skills to help patients and provide and deliver better results. So here we go. I have a patient whom I would like to discuss or telehealth with you. Of course, I can coordinate Zoom meetings. And we'll do that with all stakeholders. We can have yourself, the patient, anyone else who's involved in their care participating in those meetings via video conferencing. So easy. I've organised that. Is in chronic pain, botched rehab post-surgery on the hip, knee and lumbar spine. And that, of course, is not uncommon if you engage in rehab that doesn't fix you up effectively, and then you do have structural problems that get operated on, and then you return to the same rehab, then you actually haven't addressed the root cause of the problem. So, of course, you're not going to recover well. He's a lovely man at the end of his tether, which, of course, happens to everyone in chronic pain. You just lose the plot. There'll be other medications that interfere with your mental health as well, and your general quality of life deteriorates. So of course you start to get affected by that. He's at the end of his tether regarding his prognosis and future, but he has no underlying psychological, psychiatric or emotional problems. He's just lost and he needs some guidance. We are starting on NeuroHab this week, which is just music to my ears that we're delivering a methodology consistently all around the country now. So yeah, I look forward very much to meeting up with the fellow who sent me this and your patient, and we can sort of give him a structured roadmap, which of course is all that people need to move forward. Let's move on to the second case. Let's see if I can enlarge that a bit. Okay, thanks for an amazing course over the weekend. Is there a way we can access the course materials? Yes, everything that we delivered is getting edited now, and we're going to put it online on our web page. It's a little bit rudimentary. It's a homemade website, of course. We're just getting started, so bear with us. There'll be a members portal where this information will be uploaded. All of our talks and content will get put up there, but you've got to become a member of the college, so get in touch with us if you want to be a member. Let's see what this case is about. I have a question to run by you and the team. I have a male client that I've been working with for 2 months now. His history is compound lifting, fantastic. That defines a characteristic of a functional movement, compound joints, compound muscles, or recruiting lots of muscles. And what are we saying? Not competitive, just for himself. He's also quite lumbar dominant in his posture. So the term lumbar dominant, remember one of my early slides in the workshop was talking about precise terminologies, definitions, and consistency. I'm not really sure what you mean by lumbar dominant in posture. So I'm assuming that you may be implying that he's a bit hyperlordotic, if anything. So that's what I'm going to assume by that. But I would just use the term overlordotic or hyperlordotic in the terminology there, just so that we're consistent across the board, and when we talk to each other we know what we're talking about. Otherwise it can lead to confusion. Consistency in defined terms was my first slide. in the conference. We have done a lot of work on getting his glutes core functioning well to the point where he doesn't have that pain anymore. That's wonderful. Functioning well is the key element of that sentence. It means that core is coordinated, okay? So it's not so much necessarily stronger, but it's coordinated. Strength is great, but coordinated strength is exponentially orders of magnitude better. But what he does have is super tight calves. They try to take over when we practice the hip hinge movement at times, as opposed to his hammies working effectively. What are your thoughts on this calf tightness? I thought it was from years of perhaps having inefficient ham glute activation, and therefore his calves tried to load to support him. Any tips on the potential causes and how we move through this? Or is it a matter of keep working the glutes, hams, core properly so the calves learn to take a back seat? Absolutely. I think you're on the right track there. It's about the coordination of the posterior kinetic chain, having the hamstrings and the calf muscles and the glutes all work efficiently. So that the patient can engage in his normal lifestyle activities, and then also when he's doing physically demanding stuff like his compound lifting. There are some structural things to also take into consideration, and that is a condition called popliteal artery entrapment syndrome. So I think you're definitely on the right track with his functional training, and be happy for you to touch base with Sam to get some ideas on additional training or movement skills and drills that can be utilized to get rid of that synergistic dominance that can sometimes come up when the posterior calf musculature takes over knee flexion movement when the hamstring should be contributing, and it's usually secondary to the hamstrings just not firing correctly in a coordinated way. I bet you if you turn this patient over prone on their tummy and get them to flex their knee and just put one finger up against their heel and ask them to flex against your finger, you'll be able to easily resist their hamstring flexion capacity. So we'll get that working properly, do some further compound movements and get rid of that synergistic dominance. But if it's a real major issue and the patient is still not recovering, remember there's two things to focus on, both structure and function and demand. That was the third thing, but structure, function. We do have to assess for a structural deficit that could be contributing to the symptoms and contributing to the overall poor functioning of the system, poor stability. So popliteal artery entrapment syndrome needs to be excluded, and I can help you with that if you like. Have a look at it online, get your patient to have a read in some forums about that condition, and if it does sound like what he's going through, then it's just a matter of getting some very specialized imaging, looking both at the posterior compartment of the leg, looking at the anatomy of the popliteal artery, which sometimes can get hooked up on the gastrocnemius tendons in the popliteal triangle, and then if that is the case, then you may need to see a specialist who can decompress the popliteal artery kinking, so to speak. And I've got a network of people that can help with that and advise further. But if that condition does not exist and it's not a structural problem, then we dedicate 100% of our attention to optimizing the function of the system, and you will most likely be successful. All right, thank you so much. Bye-bye now.